Hello everybody. Today we are going to discuss about 2023 AHA focus update on adult advanced cardiovascular life support. So this includes the management in the situation of the cardiac arrest and the post cardiac arrest care. So vasopressor medications during cardiac arrest, we recommended that epinephrine be administered for patient in the cardiac arrest. It is reasonable to administer epinephrine 1 mg every 3 to 5 minutes for cardiac arrest. With respect to timing for cardiac arrest with non-shockable rhythm, it is reasonable to administer epinephrine as soon as feasible. Vasopressin alone or vasopressin plus methylprednisolone in combination with epinephrine may be considered in cardiac arrest but offers no advantage as substitute for the epinephrine. With respect to timing for cardiac arrest with shockable rhythm, it may be reasonable to administer epinephrine after initial defibrillation attempts have failed. High dose epinephrine is not recommended for routine use in cardiac arrest. Now about non-vasopressor medication during cardiac arrest. Amiodarone and lidocaine may be considered for ventricular fibrillation and pulseless ventricular tachycardia that is unresponsive for defibrillation. For patients with out-of-hospital cardiac arrest, the use of steroid during CPR is of uncertain benefit. Routine administration of calcium for treatment of cardiac arrest is not recommended. And also the routine administration of sodium bicarbonate is not recommended for patient in the cardiac arrest. Also, the routine use of magnesium for cardiac arrest is not recommended. Now about extracorporeal CPR. Use of eCPR for patient with cardiac arrest refractory to standard ACLs is reasonable to select patient when provided within appropriately trained and equipped system of care. Now the trials about the eCPR, there are two trials, that is arrest trial and hyperinvasive trial. Arrest trial demonstrated significantly improved survival to discharge and 6 months survival for patient receiving eCPR for refractory cardiac arrest with shockable presenting rhythm. About hyperinvasive trial, it did not meet the primary endpoint of 180 days neurologically favorable survival, although it did demonstrate significant benefit in 30-day survival with favorable neurological recovery. Now about percutaneous coronary intervention after cardiac arrest. Coronary angiography should be performed emergently for all cardiac arrest patients with suspected cardiac cause of arrest and ST segment elevation on ECG. Emergent coronary angiography is reasonable for selected adult patients without ST elevation on ECG but with elevated risk of significant coronary artery disease where revascularization may provide benefits such as those with shock, electrical instability, signs of significant ongoing myocardial damage or ongoing ischemia. Independent of patient neurological status, coronary angiography is reasonable in all post-cardiac arrest patients for whom coronary angiography is otherwise indicated. Emergent coronary angiography is not recommended over delayed or selective strategy in patients with ROSC after cardiac arrest in the absence of ST segment elevation, shock, electrical instability, and signs of significant myocardial damage and ongoing ischemia. So there are four RCT was studied in the NSTEMI, which was COACT trial, TOMVAC trial, EMERGE trial, and PEARL trial. So the conclusion of this RCT, there was no benefit of emergency coronary angiography over delayed coronary angiography for stable patient resuscitated from cardiac arrest without ST segment elevation. So friends, regarding this regarding the role of PCI, if there is a STEMI, then we need to we need to shift the patient to cath lab in emergency. But if it is NSTEMI, then trials are failed to show the trials are failed to demonstrate the benefit of early versus delayed coronary angiography. So in case of NSTEMI, we can wait and we can rule out the other causes of arrest. So this was all about the management during arrest. Now, how to manage after arrest. So regarding oxygenation and ventilation. So during cardiac arrest, patients are usually ventilated with 100% oxygenation. But after ROSC, the oxygenation level in the blood may vary from the patient could be hypoxic, patient could be normoxic or hyperoxic. So as these reactive oxygen species have been put forward as one of the mechanism behind hypoxic brain injury, there is a really need to limit the oxygen administration as an appealing approach. So exact study compared the oxygen saturation target of 98 to 100% to 90 to 94% in pre-hospital setting. And the study revealed significant adverse outcome associated with lower oxygen target. So what should be the oxygen target? So we need to maintain saturation between the range of 94 to 98%, and it is the prudent clinical approach. Now about ventilation. Following restoration of spontaneous circulation, elevated PaCO2 levels are frequently observed in numerous patients, leading to hypercapnic acidosis and thereby exacerbating overall acidity. So, blood carbon dioxide level plays a critical role in regulating cerebral blood flow. So, now how this blood carbon dioxide level is playing the role in maintaining the circulation of the brain. So, whenever there is increase in CO2, the blood vessels are vasodilating, and whenever there is a decrease in CO2, so blood vessels are showing the vasoconstriction. So the targeted therapeutic mild hypercapnia after cardiac arrest. So the TEM trial, which randomized 1,800 out of hospital cardiac arrest patient into two groups, that is normocapnia and mild hypercapnia. So the idea behind this trial was if we will maintain the mild hypercapnia, then it will cause vasodilation and will it help? That was the study question of this trial. And what that trial demonstrated, it did not reveal any significant difference in the functional outcome or survival rate between these two groups. Now about circulation. Ensuring adequate circulation is the paramount in post-cardiac arrest patients, considering its influence on perfusion of the brain, heart, and other organs. So persisting brain ischemia likely contribute to the outcome of the cardiac arrest patient. So after ROSC, the blood pressure may be elevated related to the use of adrenaline during cardiopulmonary resuscitation. Given the short half-life of adrenaline, that is 5 to 10 minutes, the effect will be wear off and in many cases, the patient will become hypotensive. So over recent year, four randomized trials have compared high MAP target ranging from 80 to 100 mmHg to the lower target of 60 to 70. So to maintain adequate MAP in post-cardiac arrest patient, careful fluid administration and the use of vasopressors and inotropes are the very vital strategies. So regarding cardiac function, several studies conducted primarily in the area of targeted temperature management with the temperature target of 33 to 36 degrees Celsius. And they have indicated that low cardiac arrest is frequently encountered in post-cardiac arrest patients. So this neuroprotect trial employed the invasive monitoring, incorporating fluid boluses and inotropes to enhance the cardiac index. However, this approach did not demonstrate any influence on severity of brain injury assessed via MRI or on the brain injury marker like neuron-specific NOS. Another avenue to augment the oxygen delivery is the utilization of ECMO. So recent research have ventured into the potential application of steroid for mitigating the circulatory shock and reducing the inflammatory response in post-cardiac arrest patients. So they have so the idea behind using steroid was it will reduce the inflammation and it will help in mitigating circulatory shock. So there was small study which was conducted in 100 in-hospital cardiac arrest patients, investigated, and they have studied the impact of 240 mg of hydrocortisone versus placebo. But this study did not reveal any significant disparities in blood pressure level, cardiac function, and inflammatory response as assessed by interleukin 6 levels. Now, the most controversial topic, that is temperature to control. With reperfusion of the brain, multiple pathophysiological cascade leads to the neuronal death by necrosis and apoptosis, which can be mitigated by mild hypothermia in the range of 32 to 36. So, regarding these two trials, two famous trials was published, that is TTM1, which was published in 2002, which showed the beneficial effect of inducing hypothermia in cardiac arrest patient, but TTM2 trial did not show any benefit of initiating hypothermia. So, what to do? So, the most recent European guideline, supported by several meta-analyses, concluded that rather than maintaining hypothermia, if we'll prevent the fever in patient resuscitated from cardiac arrest, then that will be of more benefit. And so there is no comment that hypothermia is beneficial or not, but what they have recommended is to maintain the temperature between the range of 32 to 34 as soon as it is practically achievable, and to sustain this temperature range for minimum duration of 24 hours in all adult cardiac arrest patients who remain comatose. Now about general intensive care. One of the initial steps in the post-resuscitation phase involves identifying underlying cause of cardiac arrest. While not specifically validated, recent guidelines recommended considering early coronary angiography for patients suspected of having myocardial ischemia. If coronary angiography fails to identify a causative lesion, then the further evaluation, including brain and the CT angiography, computed tomography, is recommended to assess for acute cerebrovascular event and pulmonary embolism. Patient without ST elevation myocardial infarction on ECG and without cardiogenic shock, coronary angiography can be delayed up to 5 days after cardiac arrest without additional risk to the patient and cardiac event. Temperature control is commonly implemented in the management of cardiac arrest survivor, but the use of short-acting sedative and opioid is generally recommended to facilitate proper ventilation and prevent shivering. It is essential to acknowledge the sedatives like propofol can potentially lead to compromised circulatory function and significant alteration in the brain function, as indicated by burst suppression pattern observed on the EEG monitor. So the potential advantages including faster awakening, fewer adverse event, fewer neuromonitoring alteration, and of alternative drugs such as dexmedetomidine, inhaled anesthetic, warrant investigation in large-scale studies. Additionally, the sustainability of the utilizing EEG to guide the depth of anesthesia in this patient remain unclear, given that certain EEG patterns may be linked to the severity of anoxic injury rather than specific sedative administered. The use of neuromuscular blockage is another contentious aspect of the management. While the neuromuscular blockage can effectively achieve the target temperature and control refractory shivering, it may also lead to the prolonged ventilatory support, extended ICU stay, and muscular weakness. The utilization of prophylactic neuromuscular blockage strategy as opposed to not using neuromuscular blocking agent was linked to improved survival rate and improved neurological outcome in cardiac arrest patients undergoing treatment. So only few and small sample size RCTs are currently available, and further research is warranted to validate this finding. So whether to use this neuromuscular blocking agent is not clear, but what they have saying is this: we need to achieve the certain degree of temperature, and the next point is we need to prevent the shivering. For that, this neuromuscular blocking agent can be used. So hemoglobin plays the pivotal role in the tissue oxygen delivery, and therefore anemia can be particularly detrimental in post-anoxic brain injury. Various transfusion trigger, both systemic and the cerebral, have been investigated, but the data supporting their role in cardiac arrest setting is limited. Given the absence of specific data on the post-anoxic brain injury, transfusion strategies currently adhere to general guidelines of the critical care. That means transfuse the blood if the HB is less than 7. Similarly, no specific recommendation on thromboprophylaxis, ulcer prophylaxis, or glucose management are present for cardiac arrest patients. So, initiating enteral nutrition early, typically within 24 to 48 hours of ICU admission, holds particular significance in cardiac arrest patients to avoid malnutrition and preserve intestinal barrier integrity. Although not specific for cardiac arrest, a recent RCT showed that early caloric restriction was associated with lower incidence of gastrointestinal intolerance and bowel ischemia than the standard caloric intake. As cardiac arrest patients, they are at high risk of intestinal ischemic injury and present often with concurrent circulatory failure after ROSC. A more restrictive calorie intake should be considered in such a patient. Patients who have been successfully resuscitated from the cardiac arrest, they are at high risk of early lower respiratory tract infection. So prophylactic antibiotic administration can reduce the risk of early pneumonia in patients with initial shockable rhythm and treated with TTM at 32 to 34 degrees Celsius, but it does not have any impact on mortality and neurological outcome. So the guidance for the treatment of seizure and status epilepticus following cardiac arrest remains unchallenged. So Telstar study showed that aggressive anti-seizure therapy was associated with significant effectiveness in seizure control when compared to standard and the less aggressive approach. Now about prognostication. In patients who remain unconscious following cardiac arrest, determining neurological prognosis is essential for informing patients' family and guiding treatment decision based on the likelihood of meaningful neurological recovery. So according to the recent systemic review and guidelines, no single predictor is entirely accurate, necessitating prognostication approach, which is based on some basic principles. So first, clinical examination is the cornerstone of prognostication, and it should be conducted after ruling out potential confounding factor such as sedative hypothermia to avoid overly pessimistic predictions. Daily clinical examination is recommended for patient undergoing temperature management, while the final prognostic assessment conducted after rewarming. A particular importance is given to the pupillary and corneal reflexes and the presence of myoclonus. However, the presence of abnormalities in the brainstem reflex and abnormal movement should always be considered in relationship with the other prognostic tools. Second, the clinician must be cautious about self-fulfilling prophecy bias, where the result of prognostic test predicting poor outcome influence the treatment decision, particularly regarding life-sustaining therapy. Third, multimodal prognostication should include, together with clinical examination, electrophysiological state and the test and the assessment of biomarker of cerebral injury and brain imaging. So, if I want to summarize, then and if I want to tell you what all prognostication markers that we should include in our post cardiac arrest management is, we should assess for the presence or absence of the pupillary and corneal reflexes at 72 hours. Then bilaterally absent N20 cortical wave at somatosensory evoke potential at 24 hours. Then highly malignant EEG pattern at more than 24 hours. Then neuron-specific enolase of more than 60 at 48 and 72 hours. Presence of status myoclonus less than 72 hours. Diffuse and extensive anoxic injury on brain CT and MRI indicate that unfavorable neurological outcome is very likely. Thank you, guys.